So demonstrating here, the student is able to determine compressibility of the vessel that he or she wishes to cannulate. The student will obviously compress externally on the model or the patient while simultaneously viewing the screen. So the student will identify compressibility on ultrasound, again stressing the importance that the student keep their eye on the screen. One nice thing about the IJ model is it gives the student an idea of what anatomy might look like with the patient, this being the clavicle, this being the neck region. Another nice feature of the model is that the two different ports, different colored dyes can be injected into the vessels, blue for venous, red for arterial. So as the student attempts cannulation of the vessel and draws back on the syringe, if they see the blue liquid, they are confident they are in the vein, whereas if they get red, then that suggests an arterial puncture. So then as the student attempts to cannulate the vessel in real time, they will position the probe as they want to, again identifying compressibility of the vein. Then as they advance their needle, they should keep an eye on the screen, not on the patient, looking for the hyperechoic needle to enter into the near field. This is known as the North Star sign, as the hyperechoic needle appears in the near field. As the student advances the needle, they should also advance their probe slightly, keeping the hyperechoic signal of the needle in view. As the student approaches the target, they should draw back on the plunger. You'll notice tenting of the vessel wall as the student approaches the target. The student should give a short jab, pulling back on the plunger. Ideally, the patient should be able to interrogate the vessel and notice the tip of the needle within the vessel. This is one of the limitations that we have with models. The anatomy will not always provide the student the optimal view of the needle intraluminally. It's also important that the student understand the necessity of pulling back on the plunger as they approach the target. As the student sees blue liquid enter into the syringe, they know that they have successfully cannulated the vein. If the student wishes to verify position, they can reorient their probe in a longitudinal manner to try and identify the tip of the needle in the vessel, which we see there as we move it back and forth. So the student can also do a longitudinal approach, again finding the compressibility of the vein. And one advantage to the longitudinal approach is that once the student identifies the vessel on the screen, ideally they should not have to move the probe. So demonstrating here, one of the effective aspects of this model is that if the student is in fact wrong and cannulates the artery, the bright red fluid will indicate that they are wrong. So this is our other model, the Blue Phantom block itself, which allows the student to practice vascular access. A few differences here is obviously we don't see any external anatomy, and when the student places the probe on the device, they're only able to see one vessel at a time. However, the student is still able to get a feel for what it's like to visualize a needle entering the vessel. So again, the student can see the compressibility on ultrasound, but a glaring difference once again is the absence of a second vessel. Again, we have the North Star appearing in the near field, which the student can follow. There we see the needle in the middle of the vessel, and for further verification you can orient the probe in the longitudinal axis and confirm the needle tip in the middle of the vessel, as seen by the hyperechoic tip moving about. Similarly, the student can also do a longitudinal approach. Frequently, many of us have experienced this as we have witnessed central lines being placed where the probe is correctly positioned, compressibility identified. The needle tip is initially noticed in the near field, but then lost as the probe is not moved. We may see pressure on the vessel, and the individual performing the procedure may assume that they are in the exact plane that they need to be. When they draw back on the vessel, though, they are unsuccessful. Eventually, as they pull back on the needle, they may see the drawback of blood. Exactly where the tip of the vessel is, though, is anybody's guess. Here, as we reorient the probe in the longitudinal view, we notice some hyperechoic signal, but we do not see the needle tip. As we draw back on the needle, we now clearly see it enter into the vessel. So this is a case of a posterior wall puncture. Currently, this is a model that the students use during the CSIE experience to learn more about placement of central lines. One unique aspect about it is that it is a transparent model, so you can look into it and see where the vessels might be and what the internal anatomy looks like. So in a way, I guess it kind of mimics ultrasound, however, in that you can look internally, but obviously has some limitations. There are these ports at various locations, one for an IJ, one for a subclavian, and the students can practice introducing a guide wire through these ports for practicing central line placement. The obvious limitation here is that it's extremely artificial and does not realistically recreate the experience.